Good morning, everyone, and welcome to EPF Congress 2021 and to session 11. It's a plenary session. We're going to be discussing health data between access, control, and ownership. Thank you very much for joining us for what promises to be a fascinating session. I'm Henry Scowcroft. I'm a patient editor at the BMJ. And we've got a really good lineup of speakers for you today on this incredibly important topic. It's a topic that's very important to us at the BMJ, and we've got a keen interest in it as part of our patient and public partnership strategy. So just to give you a sense of what to expect, first we've got a keynote talk from Maria Hagglund, who's a senior lecturer in implementation science at Uppsala MedTech Science and Innovation, and a Keane OpenNotes scholar and lecturer on medicine at Harvard Medical School. Maria is going to be sharing an overview of progress toward providing patients with access to and ownership of and control of their full electronic health records. After that, we will hear from Tessa Richards, the BMJ's senior editor for the patient partnership, about why access to personal health records is essential for patients. We will then hear from Angela Coulter, who unfortunately can't talk in person but has recorded her talk, but will be joining us for the Q&A later. Angela is a freelance researcher and a member of the BMJ Patient Advisory Panel, and we'll be discussing why patients must be in control over who gets access to their data. And finally, we've got Emma Doble, also from the BMJ Patient Editor, who will be discussing why control of data, particularly self-tracking data, must be in patients' hands. After all this, we will have a Q&A session, which we will sort of stimulate by setting you a poll to answer. So you should be able to access a poll. The question being, what is, in your opinion, the top priority regarding health data? So there are three options there for you. If you could pop your options in the poll, we can see what you all think. But without further ado, we will go over to Maria. So as I said, Maria is Associate Professor in Health Informatics. As a member of the Doble Research Consortium, she has explored the impact of patients' access to their electronic health records, including notes, through the National Swedish Patient Portal. And she leads several major research projects. So with that introduction out of the way, I will hand over to Maria.
There. Sorry about that delay. I'm now unmuted and very happy to be here. And thank you for that introduction, Henry. So I'm doing research on patients' online access to their electronic health records. Looking a lot at Sweden, of course, since that's where I'm working, but also internationally. And that's what I will be talking about today. And I'm going to have to start with a disclaimer. Of course, I promise to give a proper detailed international overview of how patients are gaining online access to their electronic health record across the world. But to do that in detail in 10 minutes is next to impossible. So I have chosen to focus on some interesting examples. And I hope that will give you lots of food for thought for the following discussions. But I'm sure that I'm going to miss out some really good examples as well. So don't hesitate to share those in the chat. I figured I'll start where I am. I'll start in Sweden with providing you with what has happened in Sweden. How did patients gain access to their electronic health records in Sweden? It actually started already in 1997. In the region of Uppsala, where I happen to live and work, where there was a GP, a general practitioner, who decided that he wanted to give his patients online access to their medical records. So he started off with a pilot of 500 patients. It was a huge success. The region decided we want to implement this for everyone, but it was shut down by the Data Inspection Board because it was illegal. According to the legislation in Sweden at the time, you had to be employed by a healthcare provider in order to have direct online access to the medical record. This, of course, caused a bit of debate, and we had to change the legislation. So we had a new Patient Data Act in place in 2008, and then we could resume the work. And in 2012, Region Uppsala was actually the first region in Sweden out of 21 to give all patients online access to their medical records. Sounds easy enough. It was actually quite controversial. There was a lot of resistance within healthcare. this is a huge culture change to open up the medical records that have traditionally been the healthcare professionals' tools. So it was far from uncontroversial. I know that we gained access in November 2012 because I was on vacation in Thailand, which seems even more exotic today than it was back then. But I had to go up to my hotel room and log in because I knew that I could finally have online access to my medical records. And I had to tweet about it as well, because if you don't tweet about it, it doesn't. Of course, this was a very local solution in Uppsala, region Uppsala. And lots of other patients wanted access as well. So in 2014, this local Uppsala solution was moved into onto a national health information exchange platform. And I've deliberately made this picture tiny so that I don't have to go into the technical details of how this platform connects to all the different electronic medical record systems in use in Sweden, but that's what it does. So as a patient, you log in one place on the national patient portal, and you have access to all your medical records, regardless of where in Sweden they have been created. And over time, the other regions connected, and in 2018, all of the 21 regions in Sweden were actually connected. But you see, it took for almost 20 years from the first pilot project until all the regions were connected. So this was far from a very easy project. But now all of the regions are connected. And what does it look like then when we log in to the medical record? Well, it looks something like this. And it's all in Swedish, so I had to use Google Translate to get it into English. But you have access to your notes, to your medications, to diagnosis. And in fact, over half of the Swedish population have logged in and accessed their medical records. So it's quite a popular e-service, not the least now during the pandemic, when this is the place you go to find your COVID-19 tests. And you get the data in a sort of timeline, and the notes look more or less exactly as what your clinicians have written in the record, including ICD-10 codes and all sorts of information. So this is one of the more used e-health services in Sweden. Of course, Sweden is not the only country doing this. Just looking to our neighbors, the Nordic countries, we have a Nordic project now called Nord eHealth, where we are looking at, we're comparing the different national solutions in the Nordic countries. So we're looking at what they are doing in Norway, for example, where they also have a national patient portal. Norway has 3 regions. 2 of them are giving patients access to their medical records online. The third one has just purchased the American EHR system Epic, and they will have their own patient portal, interestingly enough. Also in Norway, different from Sweden, is that you don't have access to the notes from your GP, only to the notes from your hospital. In Sweden, you have access to all the notes. Finland have their own national portal, MyKanta or Omakanta pages. They also have access to their entire record. But here it's a little bit different again, because all of the other functionality that you might want in a patient portal, booking appointments, renewing prescriptions, all the administrative stuff that you want to do, are separate from the Omakanta. So you have those on your local patient portal, and to Omakanta you go to access your records, which makes it a little bit different. In Estonia, they also have, of course, a national patient portal, and they are quite advanced, Estonia, in using digital platforms for their citizens. But on the national patient portal, you don't have access to all of your notes. You have access to summaries that your clinicians write for you to publish on the patient portal. So you see, it's similar, but there are important differences. And the reason why I put Denmark and Iceland in parenthesis here is not because they don't have patient portals, they most certainly do, but they are not actively participating in the Nordic Health project, but they also have similar patient portals. Looking more broadly across Europe, of course, we know that in the UK, we have the NHS app giving patients access. A little bit more difficult maybe to gain the access. You have to ask for permission to have access to your records. France are just changing from their previous version to a new version of their their patient portal. The Netherlands are working a lot with ensuring that hospitals are giving patients access to their medical records. In Germany, lots of interesting stuff is happening. And I don't have time to go into what's happening all across Europe. But as you can see, there's a lot of things going on. Going across the Atlantic in the US, of course, there's the OpenNotes research team. You should go and take a look at their website if you're interested in what's happening there. And this map is a little bit old, from 2018. I know that over 50 million patients have access to their notes now, or the notes in the record in the US. And as of April, it's actually mandatory. The new legislation makes it mandatory for healthcare providers to give patients online access to their records. And they even have financial incentives, I've said, but fines, quite heavy fines, if you do not give patients online access to their information. So this has caused quite a stir in the US, and it will be very interesting to see what happens there in the future. Canada, of course, there are lots of good examples there as well. I picked one, the University Health Network in Toronto have a very nice patient portal where they give patients access to their medical records. So far, not really a national solution here, and similarly to as in the US, not a national solution. Australia, however, does have a national solution, My Health Records. And apparently they have over 23 million records, My Health Records activated. And it's a national solution, but it requires uploading of documents from patients and clinicians. So it's a bit more work to get data onto your My Health record. Again, a somewhat different type of solution. India will be a country that is really interesting to follow now. They've just launched their National Digital Health Mission, which will include a unified health interface on an open interoperable platform connecting different digital health solutions across India. A completely different context, huge. I'm fascinated by this. I'm really looking forward to following what's happening there. And I linked here to a blog post on the BMJ about this, or an opinion piece. Similar things are happening in South Korea. There's a personal health record, and Singapore also have a national personal patient platform. So there are things going on more or less all over the world. Now, in my final seconds of my presentations, so what do we have in common and what differs between these? It might sound very similar. We have these national or local platforms giving patients access. I've just highlighted that the infrastructure makes a huge difference. Whether you have a national patient portal, you can log in and access information from all of your health records, or if you have to keep track of when you switch between providers, you have to switch patient portal as well. Your data will be a little bit more fragmented. And of course, there are really important questions that we need answered. What information do we have access to? Is it everything? Or is it part of the record? Is it only from the hospitals, or is it only from primary care? Do I have access to inpatient notes? And we see huge differences here across these settings. When do you have access? Do you have direct access, or is it a delay? Many patient portals implement an embargo time. You have access to your notes, for example, 2 weeks after the visit, which for many patients is less useful. And who decides? Is it up to the patient? I want to have access to my record, or do you have to ask permission to access them? How do you access them? In Sweden, we have something called a bank ID, which in theory sounds very easy, but for many, especially elderly, it can be quite difficult to download and use. And last but not least, who controls the access? Can the patient control access? Can the patient control who else has access to this data? And this is something that we will be discussing more during this session. And who does have access? As the more we sort of gather all this information, the more interesting it becomes for researchers, for industry, for third parties who might want to have access to this data. And how do we ensure that patients are in control? That was it for me. Thank you very much. Don't hesitate to contact us if you have any. We are always looking for more examples of what's going on. So please share with me whatever's happening in your countries. Thank you.
It had to happen at some point, didn't it? Sorry about that. Thank you, Maria. That was a fantastic overview of some really exciting work going on all around the world, actually. And it'll be fascinating to see how all this pans out over the next few years. Next, we have Dr. Tessa Richards. Tessa is a senior editor at the BMJ and has been the driving force behind leading and developing the journal's patient and public partnership strategy, and is now working to advance its spread across the BMJ company. Tessa trained work as a general physician, a rheumatologist, and general practitioner before joining the BMJ. But she's really led the journal's practice, education, and analysis sections and established several influential series, including the Diagnosis Too Much Medicine series, in addition to continuing part-time clinical work. A regular writer and speaker on the importance of patient and public partnership, she lives with stage 4 cancer and pernicious anemia as a carer for close family members with a variety of long-term conditions. Tessa, over to you.
Well, hello, everyone. It's a great privilege to be able to have the opportunity to share my views on why it's so important for patients to have full, free, real-time access to and interactive use of the electronic health records. And thank you very much, Maria, for those great provocative questions, because it's far from universal, it's far from comprehensive. And I think the frustration of this is expressed in this message on the mug from e-patient Dave de Broncard. Give me my damn data. His activism for patient engagement and empowerment stems from his diagnosis of metastatic renal cancer 15 years ago. It galvanized him to go to an online renal cancer patient community for advice, get hold of his medical records, and seek a remarkably successful new therapy. He then went on to write a book called Let Patients Help. In this book, he cites a senior physician at the Beth Israel Deaconess Medical Center in Boston, Warner Slack, who back in 1970 observed that patients are health system's most underused resource and that we can't expect them to do their best to be responsive and responsible partners in care if we hide data from them. In the same book, Eric Topol advises patients to take charge and seize your own data. Well, close to a decade on, many of us are still struggling to do that. There are no shortage of policy pledges to share personal electronic health records with patients, but providers in many countries are struggling to make it happen for a variety of technical, organizational, governance, and cultural reasons. I keep a paper file of my records and I spend hours chasing departments for test results. At least my GP practice no longer charges me when I ask for copies of my data, but they don't have all of it, for in the UK, primary and secondary care IT systems are not interoperable. Managing this file is a bit like doing a difficult jigsaw with missing pieces. Contrast this with the instant access we all have to our health information. The rationale for access to personal health information must surely start with the fact that it's a legal right. And as Maria says, that's been put into sharp focus in the US this year with the passing of the 21st Century Cure Act on the 5th of April, which mandates access to all health information in the electronic medical records without charge and without delay. The resources listed at the bottom of this slide collectively show just how positive an impact patient access to electronic health records has on patients and health professionals. The benefits include correcting errors and omissions in the notes, promoting health literacy and self-management, fostering trust and improving communication between patients and health professionals, and avoiding costly and distressing breakdowns of care in an increasingly fragmented healthcare world. This paper looks at the frequency and types of patient-reported errors in the electronic health system, and it's one of the largest recent surveys. A fifth of over 20,000 respondents to a survey of patients with access to their notes in 3 US healthcare organizations reported they contain mistakes, and they judged 40% of these to be serious. Errors ranged from incorrect histories, inappropriate referrals, and medication errors, which are very common, to documentation of examinations, tests, and discussions which, patients said, did not occur. The authors flagged that it's very hard to get errors corrected, and the second paper on this slide shows that that's because there's seldom a clear mechanism to do this, and patients worry that if they do, they'll be labelled as troublemakers. If patients could routinely read their notes and draw attention to these errors and omissions and misunderstanding in a non-pejorative and timely way, it will surely help make care safer. And encouragingly, the World Health Organization's latest Global Patient Safety Action Plan explicitly recommends patient access to their medical records and the ability to escalate concerns to healthcare organizations. Health literacy, as many of you will know, is widely defined as the capacity of individuals to obtain, process, and understand the basic health information and services they need to make appropriate decisions. Evidence shows a clear link between health literacy levels and health outcomes and costs to health systems. The less literate do badly on all counts. Easy access to personal health information and data online provides patients and those who care for them with a springboard and a powerful incentive to explore and learn about their own health status and put this in context with generic health information and act on it. But for all to benefit, obviously, the digital divide has to be tackled. And one interesting initiative comes from Australia again. This is the Health My Way programme, which has been set up by the National Digital Health Agency in partnership with the Social Change charity, which trains community-based digital health mentors who help senior citizens, people with disabilities, and those from culturally or linguistically diverse groups to understand how to access and use Australia's national online health record system and access information online. But health literacy is a two-way street. Doctors struggle with patients with complex problems who are unable to give a clear account of their medical journey and its treatment. They're labelled poor historians, and no thought is given to the nature and quality of the information they are able to access or whether they can understand it. Not before time. It's now being acknowledged that healthcare organizations have a responsibility and an obligation to be health literate too. For the first time in 20 years, the US Healthy People Framework has come up with a new definition of health literacy. This states that is not just related to the capacity of individuals, but to an organization's ability to make health-related information and services equitably accessible and comprehensive. Eureka! Let's pin that message on every health professional's wall. For me, there's no more persuasive illustration of the advantage of sharing personal electronic health records with patients than that provided by the UK GP, Dr. Amir Hanan. He started sharing health records with his patients 16 years ago to promote transparency and trust with a community of patients who had been shaken to the core after their long-standing GP, Harold Shipman, was convicted of being a serial killer responsible for death by IV morphine to over 250 of his elderly patients. From the outset, Amir prioritized transparency and joint working with patients and giving them the option to access their electronic health records. Before they do, they're well briefed about what it entails and their rights to determine who to share information with. Most have taken up this option. And if you go to the Horton Thornley website, you'll see why Amir got an MBE of the Queen's New Year's Honours List. It's an absolute treasure trove of information and learning on how to access information and use digital resources to help patients fill in gaps in care and manage their own health problems. There are other new initiatives to extend the electronic health records in many other settings, including using them to embed tailored decision support systems to facilitate informed, preference-based decision-making. Avoiding breakdowns of care Well, we know that navigating complex health systems greatly adds to patients' burden, and so does the trend from multiple referrals to specialists and failure to prioritize continuity of care, even though we know that it results in better health outcomes. Duplication of assessments, tests, and investigations is costly, and on occasions leave patients falling between the cracks and finding no one is following up. Giving patients access to electronic health records and the opportunity to use them as a communication tool can empower them to bridge these gaps. And an example of how this is being done is set out in this BMJ blog, which is jointly written by patients from Harvard and the patients and the doctors who've been developing this new tool called Our Diagnosis. Patients can set the agenda for the outpatient visit in advance and mention any healthcare interventions they've had with other providers since they were last seen. Doctors can read the notes in advance and order appropriate tests prior to the consultation. Early feedback suggests this helps make best use of very time-limited consultations and has the potential to really reduce breakdowns in care. There's another new initiative trialled in the UK is using the record to facilitate informed consent for planned interventions in advance and to initiate what I put here as PIFUs, which are patient-initiated follow-up appointments, because at the moment these appointments are just plucked out of air in an arbitrary way, one doctor's best guess of when patients need to be seen. Of course, advocacy for patient access to electronic health records needs to be accompanied by advocacy for co-design and co-evaluation of the impact of using them. Giving patients access to badly organized, poorly presented information that is opaque and full of jargon and contains reams of irrelevant duplicate information is simply just not helpful. And Maria's already flagged what I think is the most marvelous example of the co-developed patient portal, which is My UHN portal, which is used by patients attending the Toronto Hospitals Network. And this article is worth a read because it explains how it was done and the lessons learned from the exercise. The pandemic has made us all think of the opportunities new technologies bring for patients to play a more active part in co-management of their health and well-being. Providing patients with real-time access to their full electronic health records and the opportunity to use these is, in my view, the most important of all. We know the future is here in some places, and I think patient activism will help ensure that it becomes more evenly distributed. Thank you.
Wonderful. Thank you, Tessa. I'm just checking I'm not on mute this time. I'm not. Good. That was a brilliant overview, Tessa. Thank you so much for that. We're now going to hear from Angela Coulter. Angela is a UK-based health policy analyst and researcher with special interests in patient and public involvement. Social scientist by training, she has higher degrees in health service research from the University of London and the University of Oxford, and currently chairs several committees, including the Public Advisory Board of Health Data Research UK. Now freelance, Angela's previous roles include Chief Executive of the Picker Institute Europe, Director of Policy and Development at the King's Fund, Director of Health Service Research at the University of Oxford, Director of Global Initiatives at the Informed Medicine's Decision Foundation, and Honorary Professor at the University of Southern Denmark. Angela can't join us exactly at this moment because she is in transit, but will be joining us for the Q&A. But Angela has recorded a video of her talk, which we'll now play for you.
Hello. The topic I've been asked to talk to you about is why patients must have more control over who can access their health records and how this can be achieved. Before I start, though, I should explain where I'm coming from. I chair the Public Advisory Board of Health Data Research UK, which is the UK's Institute for Health Data Science. And I'm also a member of the BMJ's International Patient Advisory Panel. Now, you've heard already about individual use of health records. I'm going to talk about aggregated use, and in particular, their use for research and innovation. The COVID pandemic has taught us a lot about the potential benefits of using health records for research. We've learned an awful lot about COVID ever since the pandemic started. And much of that learning has come from the use of aggregated health records. But with that benefit comes some challenges. Many patients have never even seen their own records and have little or no control over who can view them. Data custodians are often slow to respond to researchers, and researchers feel that this inhibits their timely access to research, which of course was very important during the pandemic. Distributing the data, by which I mean giving it to people, to researchers to use, increases the risks, particularly the risk of re-identification, because we're usually talking here about anonymized records, but it's never possible to completely anonymize records. And the risk of re-identification is something that patients worry a lot about because of their completely legitimate concern about privacy. And finally, data governance processes, which during the pandemic were often relaxed to enable the research to go forward, but they are processes that were developed some time ago, and they often lack transparency and common standards. And a particular concern is the public is really rarely involved in them. Now, during the pandemic, there's also been quite a bit of research in the UK, and I must confess that I'm speaking very much from a UK perspective, but I hope this is relevant in other European countries too. Patients say that, of course, they recognise that their records contain personal information, often sensitive information, and they are very concerned to protect their privacy and confidentiality. But most people are content for their data to be used if it's anonymized and if it's used for public benefit. There is some concern about commercial use of health data, especially concern about its use for marketing or insurance purposes. So the data custodians must demonstrate that they're trustworthy and that all of us can trust them to respect concerns about privacy, confidentiality, and so on. Patients in many countries have the right to opt out of this. Certainly they do in the UK, but opting out is a very blunt instrument. If you opt out altogether of having your data used for any purpose, then of course you're not able to contribute to the potential public benefits of their use. And if many people opt out, it really reduces the likelihood that the research is going to have useful findings. An organization called Understanding Patient Data is one that I want to recommend to you, because they've done a lot of thinking about this, and particularly thinking in consultation with the public. You can find their work on their website. Another set of thinking that's been done is how to actually access, how to ensure that access to aggregated data respects privacy and keeps the data as safe as possible. And in the UK, these standards are now recommended for use by all data custodians before deciding to share their data. They're called the 5 safes. Safe people, that means the people who should be able to access the data are those who are trained and accredited. They've gone through an approval process. The projects that they are going to work on have to be seen to be ethical and to produce public benefit, and that must be clear before they're given access to the data. The settings in which the data are analysed also need to be safe. And increasingly, we're thinking that the best way to do that is to establish what we call trusted research environments, or TREs, which the best way to explain this is that it's more like a reference library than a lending library. So instead of giving out the data, which of course it could be used well, but then what happens to it afterwards? Who else can access it? How can we be certain that it's kept safe? Whereas if it's a reference, uses like a reference library, then the researchers come to the data rather than the other way around. So they can analyze the data, but and it will be pre-anonymized, but they cannot take it away to analyze on their own computer. The outputs, once the data have gone through this process, must be checked and validated again to ensure that no personal data is removed and that it should all be de-identified. So the experience that we've had so far of this process, and I think there's a lot more learning that has to be done, but these would lead me to make the following recommendations. Firstly, that all patients must be given access to their full health record, and they should be able to indicate their preferences on whether it's used and how it's used. That should be possible either within the record or externally to the record. So maintaining the right to opt out for any use you're not happy with. The public needs to be consulted about what their views on secure use and public benefit. Patients and public representatives should be involved in the data governance processes. So there should be lay membership of all these data access committees. The 5 SAFEs criteria should be adopted by these committees, and data custodians should be required to publish registers detailing who has used the data they hold and for what purpose. And finally, the results of these analyses should be accessible to ordinary people, always published and published preferably on websites that are clear and comprehensible. Thank you very much for listening.
Great. Thank you for that, Angela. Great presentation. Just before we go to our next talk, just a reminder, the poll is still open and will be closing during the next session. So if you haven't voted yet, do pop your responses in there. Right, our last speaker before we go to the Q&A is Emma Doble. Emma joined the BMJ in 2018 as the patient editor for the journal's education section. Since 2020, she's also led on the patient and public partnership strategy. Her work includes managing the What Your Patient is Thinking series, supporting patient partnership across the BMJ events, and advising on patient partnership across all BMJ journals. At the age of 4, Emma was diagnosed with type 1 diabetes, which she struggled to manage growing up. She set up and developed a number of projects to initiate peer support for young people with type 1 diabetes to help others manage and cope with their condition. And her interest in patient partnership began when she began working with her local diabetes team to review and redesign the diabetes service, all the while completing her MSc in health psychology. As well as her work with the BMJ, Emma works with Cochrane UK as a patient coordinator, focusing on encouraging wider connections between the organisation and patients. Emma, over to you.
Thank you, Henry, for that very comprehensive review. And I love the fact that you mentioned about my life with type 1, because I always describe that as my real, proper, full-time job, living and managing type 1 diabetes. So as Henry said, I was diagnosed when I was 4 years old. I was diagnosed in 1994. So as you can imagine, the information and technology and data that we had available to us in managing my condition was extremely limited. Back then, I had just the opportunity to do a couple of blood tests a day, and that's about all I had to manage my condition every day. I was brought into hospital every 6 months and received a long-standing what was known as an HbA1c, which gives me an indication of how I'd been managing my condition for the last 3 months. And that was about all that we got. And about 5 years ago now, we were all in our local kind of community in diabetes were granted access to our health information. And this is what I received. So this is my data from back to the day that I was diagnosed of my HbA1c results, all the way through up until more recently when I was back in the service again. And so this, having access to this was interesting. It was nice to go back and see this information. But if I'm honest, it wasn't hugely useful. And even getting this information, having this presented and being able to access it ahead of my consultations with my GPs and my consultants, it wasn't massively useful to me in helping me manage my condition in the day-to-day aspects of it. So fast forward to now, this is a snapshot really of the amount of information and data that I have on managing my condition. So the first graph there is a daily graph that I have, which shows you my blood sugar levels throughout constantly in real time. I can then provide you with information for the previous week on where my blood sugars have been, what the average has been per hour, where I've experienced low blood sugar levels, so hypos, when I've been in target, the percentage of time, and that number at the end, the 6.1, that is my diabetes technology now estimating for me that blood sugar test that I got at my healthcare professional provider every 6 months when I was first diagnosed. So the world that I live in diabetes has moved on hugely, and the amount of information and data that we have available to us through all of the technology that we wear has changed the way that we manage our condition dramatically. And it's really moved the power dynamic of the consultation away from us having to wait for our healthcare professional to tell us what our HbA1c was, to now me having all of that information and actually my healthcare professionals asking for me, where are things at? What do I think? What's the information that I have? And I'm very lucky in a position that I can share this with my healthcare team. They can access this. I'm currently pregnant and have a weekly phone call with my consultant every week, and we can both access all of this information and can go through it together. And the power dynamic between our consultation has shifted dramatically because of that. And it's been such a game changer for me in managing my condition on a day-to-day basis. Now, getting all this access and control of this data has been hugely important and hugely helpful, but it's also brought up a lot of questions for us in the diabetes world around who has access to this, who controls this, and how do they determine who and what and how this is delivered, because this is so incredibly important to us, but also to our healthcare professionals now. So I wanted to quickly talk about Tesco's. Tesco's is a huge supermarket chain in the UK. And back in the early 90s, they introduced what they called their club card scheme. So rather than just giving customers vouchers for money off when they came and shopped in a shop, they created this card. And every time a customer went into the shop to buy their groceries, they had to scan this card. They got vouchers and discounts, but they also collected all of the data on what they were buying, when they were buying, and how they were buying. And when they introduced this, there was a huge amount of excitement around this because vouchers became personalised. The offers that you received and that you got from Tesco's matched what you tended to buy, which was very exciting and amazing for a lot of people. And the chairman of Tesco's, when his marketing team came with him to this idea, he said, "This is amazing and fantastic. I have one concern." And the team said, "Well, what's the concern?" And he said, "You're going to have more information on our customers in 3 months than I've gathered in the last 30 years. And I think in that, we can really see what the value of our data and our information is, and that creates a huge power balance in the world where this data is being created and where it is being used, because anything of value that is of use to anybody is going to be difficult to manage, and think about how we use that in the best way for all of those involved. So when we talk about patient data, I'm going to use the term owns or ownership, but I think this is really difficult to define. Data in itself, since it's been digitalized, is almost impossible now to kind of think about who owns it. But often when we think about who owns the data itself, a lot of people's first response would be the patient. Absolutely. They should be able to own it. They should be able to control it. But it's really just not that simple. And actually, the move of data onto being digitalized has made this even more complex, because now we have things like data mining. Data can be anonymized. It can be used in research. It can be used by companies. It can be used in all sorts of ways. And actually, we don't have anybody who has real ownership on how that is used and by whom. So this is something that in the diabetes world, we are quite concerned about, and we really want to explore how we should answer this question. Why is it important for me to define this? Well, the first thing is having autonomy and also the power over my own body and the data that it creates. As I've said, this data and information is incredibly powerful, but also being able to use it in a way that suits me, in a way that I can actually access it and use it, is incredibly important. It's no point use to me if it's stuck behind some paywall or it's stuck in a system that I can't use. The second is around privacy and data protection. I think privacy is particularly important for us with these kind of technologies, which are collecting data all the time. When Tesco introduced their club cards, there was lots of stories that Tesco could predict when a household was due to have another child. They could tell these things by looking at what you're buying. I'm pretty sure my diabetes technology could tell you a heck of a lot more private information about me if you really wanted to go and have a look at it. And data protection is obviously a huge issue. Knowing where that information is going and who has access to it, who has control over it, is really important for me. And I think lastly, on both of the other talks that we've had around access and control, it's important for me to have both the access for myself to use it, but also being able to grant it to others. So I can currently control whether my healthcare professionals can use my information. I can also deny them at any point and stop them accessing this information. And it's really important for me to have the full control over all of that. So is ownership of health data really possible? As I've said, I think this is a very difficult question to answer. I think the kind of control of digital information is impossible, really. And once it's out there, it's out there. It's very difficult to think about who has overarching rights and responsibilities for that information. It's very difficult to define. I think informed consent is also incredibly complex. Often when with my technology, I sign up to their terms and conditions. I click yes, which gives me access, but I also sign up to who knows what, and the companies have full control over what they do with that information. And I'm very uninformed about it, to be honest with you. And I think the third one is the ethical challenges. I think access to data can be a very positive thing. A lot of people are very happy for their information to be out there, to be used in what they would deem good things and positive things. But I think everybody's interpretation of what they would be happy for their data to be used for is probably very different. And how we manage that is very challenging. So I'm going to unfortunately end this with probably more questions than answers. I think we really need to think about what do we do next in terms of patient data and access and records and the control of those. So who should really own patient data and records? Is it the patients, healthcare professionals, healthcare organizations, commercial bodies, or should we all be taking a bit of ownership and the rights and responsibilities of health data? How is it decided and how is this implemented? We've already seen how challenging it is just to decide and implement access, never mind managing everything behind this. How is this role of ownership monitored? Who has the overall say as to what can be accessed, who can have access, who can control this information? And should this be the same across all health data and records? Obviously, mine has been very on the kind of self-monitoring devices, but should that be the same across everything? So thank you so much, and really excited to hear your questions and thoughts on this as well.
Wonderful. Thank you, Emma. And I think some really provocative questions there to kick off the discussion on this. The poll is closed. I have the final results here, and speaking very much to the questions Emma has raised, the thing that most of you think is the most important aspect is the right to determine which third parties have access to use and access and use of data. 44% of people felt that was the most important, followed by access itself. 36% of you felt that it's free, immediate online access to health information test results. And 20% of you felt that the most important thing was the ability to hold, control and share personal health information collected via personal tracking devices. So I think that top part of that is the right to determine who else has access is a fascinating place to start. And I wonder, it feels like there ought to be some kind of console where you can tick boxes to say who can and can't. Maria, I wonder if we start with you and say, do you know, how does this work in systems you've seen, and how do people have the right to determine? And if any else, others of you want to chip in after that, but Maria, let's go to you first.
Mm-hmm. Very, very differently, I might start by saying it varies a lot. And I think that when it comes to just starting from Sweden, the Swedish perspective, we often have something referred to as shared electronic health records, where healthcare providers have been able to access, with the patient's consent, data from other healthcare providers for quite some time. Through the National Patient Portal, I, as a patient, can decide to block certain parts of my record, but it's on a very blunt level. It's quite difficult. If I want to block something, it's blocked for lots of people, and it might have, detrimental effects to very few people use it, because it's on such a sort of, it's not fine-tuned enough. I think that's one major issue, is actually having the technical ability. Yeah. It shouldn't be possible, but our EHR systems are not built for this level of granularity of having patients as those kinds of users. And I think that that's also something that comes in. I remember when Australia first launched their My Health record, a lot of the controversy around it was that it was, on the one hand, giving patients access to their records, but on the other hand, giving other healthcare professionals access to the same record. So this was one of the more controversial issues there, that, well, do I want everyone else to have access to my records from different healthcare providers? So it's not easy. And if we're looking at the US new legislation there now, this also changes that. I think that there might also be cultural aspects in this. So us in Sweden, for example, we're very sort of trusting towards the public sector, and we want them to have our data, and we're very concerned about letting third-party vendors have access to this health data. And the legislation is quite strong. The healthcare provider has the obligation to protect patients' data from third-party vendors. Whereas the new legislation in the US has opened up for, you have to release data to third-party vendors if the patients request it. So most people are looking for, I'll use my Apple phone health record app to sort of gather all the data from my healthcare providers, trusting very much that this then third-party vendor will use my data responsibly. So it's difficult.
It does feel like as much of an issue for UX design and for to actually get this right in terms of a way that people can understand. I mean, I just even remember thinking going to my Facebook account and trying to change advertising settings is a very difficult. And if Facebook can't crack it, it's going to be a difficult one. But it feels like the absolute priority to get this right. Emma, in your devices that you use, what exists in them?
Yeah, it's really complicated. And actually just this morning, there's been a whole Twitter storm because one of the really popular apps in the diabetes world has now just been told that they will no longer get access to the technology companies are now withholding the information from them. And from a patient perspective, that's incredibly frustrating because a lot of people use these apps to sort of bring all their information together for themselves. But actually, they've got no say as to who and how this is being done. And I think it's very difficult. I don't think there is an easy answer. I think if there was, we would probably have cracked it by now. Because I think it's just there's so many people involved at different levels. And I think I completely agree with Maria. I'm sure that there's a cultural element to it as well of trust. I think that's huge in this.
Has anyone else got anything to add on access to on sharing rights? Tessa or Angela, if you're there. Angela.
Yes, I think it's important to remember, and apologies everybody if I'm not coming across very clearly, I'm in a car on my mobile, but hopefully you can hear me. It's important to remember that a huge amount of what we learned from the COVID pandemic about the risks of transmission, et cetera, came from careful use of patient records. So there are huge benefits to be got. What we know, certainly from the UK experience, is that most people are happy to have their data used for good, well-conducted, bona fide research, which will lead to public benefit. But they are also, of course, like everybody else, very concerned about privacy. So if we can make sure that people that data is protected, that no personal details are ever identifiable, and yet we can use the data to do good research, that's the trick we need to pull. And that's why in my talk I was suggesting that the trusted research environments are the way to go. But in order to trust the trusted research environment, you need public involvement, independent people looking at how they work, making sure that all risks, all privacy risks are dealt with in a way that means that everybody's individual data is absolutely secure. And the good news, I think, is that we're beginning to do that. It's still at the very early stage, and we still need to make sure that we can do it in a way that the researchers can use the data. But securing people's privacy is number one priority in order to create public benefit over personal data, public benefit that everybody will potentially benefit from, like our improved knowledge of this wretched pandemic. If we can get there, and I think we've made some pretty important steps in that direction now, then I think it's a win-win. And that's, I think, what we must argue for.
That's a great point. Thank you, Angela. We've got 3 minutes left, and we've got a couple of questions I wanted to get to. We did talk about interoperability between different countries as people move around or move countries or go on holiday. Tessa or Maria, would you like to come in on that question?
Just briefly to say that I think it's extremely important, certainly within Europe. Sadly, Britain is no longer part of that, the EU, but the right to cross-border healthcare is there. Well, if you can't get your records across, that's a huge problem. And the EU has invested in common European health cards and how you might make that happen for decades, and it's not happened yet. I think that should have a priority, as it should. Internationally, I can use my Barclay card anywhere. Why can't, I would love to be able to use, and I'd feel a lot safer as I was going about if I could use some sort of electronic health card which had my data. I think just very quickly to return to this sort of trust and privacy issue, it's obviously confidential, it's fundamental. So for heaven's sake, let's involve patients in how we do that and how we show that it's done. I mean, most of us, if we've traveled anywhere, we've been sort of plagued with passenger locator forms and NHS track and trace and whatever, and somebody suddenly says, "Oh, we take your data privacy very seriously." They don't explain how, maybe there's a link somewhere or whatever. Like everything else in healthcare, it's better if it's co-developed and evaluated with the patient community.
Thank you. Maria, we talked very briefly before about the idea of an overarching body to set standards for all of this. How does that sit with you?
Well, there are a few internationally open source standards like OpenAir. HL7, of course, is another, not a different type of standard for EHR interoperability. So there are ways that we could do this, but of course we need to get EHR vendors on board with using these standards. And I just want to add, having recently had the experience of moving from Sweden to the US and back again, international interoperability is really, it would be excellent. But just having access to my Swedish records on my smartphone and being able to show them or, read from them myself and translating to the physicians that I met in the US was also really helpful, even if it's manually done. But just having that access actually helps you as a patient as well.
Fantastic.
Very personal experience.
We've got 28 seconds left, so I'm going to have to stop the discussion there, although this is absolutely fascinating. I feel like we could talk for another half an hour at least on this. BMJ has some webinars of its own coming up over the next month or so, looking into patient access to healthcare records. You can find details on the BMJ's Twitter feeds and presumably elsewhere soon. But I just want to thank everyone who's been involved in this. Sorry we haven't had more time for discussion because there's so much to discuss, but I hope this has given a sense of the scope of this area and how much that promise there is for the future in it. And just thank all the speakers today. It's been a wonderful session. Thank you.